I was given the topic of discussing novel therapies for atopic dermatitis in 20 minutes with a focus on biologics, and poor Brent King doesn't have an easy task of doing basically JAK inhibitors for atopic derm and alopecia areata and anything else he wants to do. So between the two of us, there's a lot of stuff to cover, but that's really the takeaway of this, which is that there's an incredible amount of therapies that we have in hand. Here's a list of I think probably not even up-to-date list of companies that we've done work with in San Diego. Sort of, there's an incredible amount of novel therapies that are in hand or about to be in hand for atopic dermatitis. So I thought I'd start with just a basic reflection. First of all, it is great to be at a live meeting, albeit if it's a hybrid meeting as well. We just heard Jonathan long distance. But during our time of COVID, we were just getting our first newly approved systemic agent for atopic dermatitis, and then others rapidly developing. And so the gestation time period of us moving into our newer age of therapy happened with us being together, but not being together in groups of people to process this. So it's been a time also of incredible change in the field. So our first systemic biologic agent was approved in March 2017. We have new topical therapies approved and in late phase studies, new indications by age, new biologic agents, and then the oral JAKs that are on horizon as well. But on the bottom is really the important thing, which is that we get information, we get labels and approval, and then we have to sort of process that both as clinicians and as patients. And basically, I will show you in my tension of this talk summary slides of sort of where a particular drug may be at and my thoughts of where that drug is, along with some data. But I could not start to do some of the data interpretation of newer data for each drug because we do that in different venues, and it takes a lot of time to go through all those data and to process them. So I wanted to quickly discuss topicals before I go on to systemic biologics, just because topical ruxolitinib is something we just recently got approved in the U.S. And by the way, this is an international meeting, but I'm going to be biased to drugs that are in hand or about to be in hand because those are the ones that we're dealing with. But there is some differential around the world in terms of where we're at with approval status. So topical ruxolitinib, interestingly, just got approved. It got approved on its short-term study without inclusion of the long-term study, just to let you know there's some issues involved in that. The drug that's approved is 1.5% BID application. Their core study was a 8-week BID application, but then a long-term extension study that was done essentially in a discontinuous methodology where it was used when there was active disease. Patients were clear or almost clear. They could stop using the medicine. And that sort of reflected in the label, but in terms of long-term or non-continuous use. But the label data actually doesn't include the long-term studies, which is something that you'll see. This is a roll-up of the phase 3 clinical trials. If you look at about 50% of patients making it to clear or almost clear, EASI-75 or around 62%, nice itch reduction as well. Very rapid itch response with the topical JAK inhibitor. And safety data that actually looked pretty good in terms of discontinuations. Tolerance of this drug appears quite good in the clinical trials, just now into our hands clinically. In the longer-term study, there was a median of 116 days in the one-year extension trial of untreated skin, so people were really using it off and on. There could have been some people who used it continuously. And there's a published pharmacokinetics paper that didn't show correlation between Cmax and hematologic changes, but there is a bioavailability issue such that the drug's approved with a limit of 20% body surface area, which I think is a very appropriate window. On the other hand, we have a label that we're going to have to deal with in the field where the label lists safety issues and concerns with the oral JAK inhibitors many of which were not seen in the topical program, and so the sort of differential in the prescribing label from the clinical studies, but something we're going to have to deal with in clinical practice and are starting to already. Other topicals that are well along the way development pathway are tapinarof, where they have both their adult studies and pediatric studies in trial, and roflumilast, so one being a novel aryl hydrocarbon receptor modulating agent, and flumilast, a new PDE4, well along the way in clinical trials. A negative result, our first prospective prospective microbiologic agent intervention for atopic dermatitis based on NIH research on Roseamonas being decreased in atopic dermatitis patients and more present in healthy skin. And the initial data looked quite good in uncontrolled trials, but the vehicle controlled trial was a negative trial. And so basically we had our first failed microbial-based intervention. And we'll see if Rich Gallo, who'll be speaking from San Diego, be speaking later in this meeting. He had a Nature Medicine article which sort of summarized their work with a different human commensal Staph hominis, which can block Staph aureus. Now, I was tasked to discuss mostly biologic agents, and let's move on to where we're at. And I figured I'd start with a big overview on where we are, and certainly the sort of 32,000-foot view is that dupilumab was our leader as the IL-4/13 blocker. It's been about 3.5 years since the approval in adults. Was followed in March 2019 in the 12-year-old plus, and then followed by 6-year-old plus, and I'll show you shortly the new data down to 6 months of age. So which I think will be really quite remarkable change in the field, especially as a pediatric dermatologist. I'll tell you the approval down to age 6 markedly changed clinical practice, but also the psychology, I think, of the pediatric community in being aware of systemic agents for atopic dermatitis. And then I'm going to give you some examples of some of the data that we sort of wrestle with, but the summary is that we have extended studies plus real-world collection of data, plus our own individual and cumulative clinical experience that inform how we're doing with the drug. So when I have someone who's finished 2 years of dupilumab, and I'm having their anniversary visit when we're going into their third, I call it an anniversary visit and discuss how they're doing in relationship to their disease. And I've also let them know, how is the drug doing? How is it performing in some of the longer term data sets that we're seeing in, and those of us who have to review these things sort of know where those data sets are at. So this is an example of the Liberty. This is an open label extension actually of weekly dupilumab. It's the sort of data charts that we see. These were patients who had on 300 milligrams of dupi with a 172-week cutoff. I believe Lisa Beck's going to be discussing the study in more detail over the weekend. But it's the kind of data sets that we get where we're looking at how many patients dropped, what were the discontinuations from. The real question being, right, just step away from the data, what's happening with long-term use of the drug? Is there something coming to bite us? Is there evidence of immunosuppression? We're allowed to say this drug isn't an immunosuppression. Is there something different in terms of the data sets? And some of the problems we have is that we have decreasing numbers of patients who continue on in study circumstances, especially when the drug's available open label. So my summary is, the data sets look similar to early data without evidence of problems with extended use. We've seen in other presentations, this was EADV 2020, specifically, for instance, at the blood tests in continued use of dupilumab, which still rationalizes no need for blood tests from use of the drug. But in the clinical studies, there are people who've extended beyond the initial 16 weeks or 1 year of study. And then we've seen studies such as this looking at what happens with individuals who remain on the drug for a long period of time. You see we're down to 172 weeks. But one of the problems we face is look at the numbers. So when they started in the initial study, they had about 2,600 patients in the study. When we're looking at the end of the study, there are 149 patients who've reached that data point. And when we're looking at a poster, we can't really know how many patients are in the study and didn't meet that data point, or how many patients left the study because they could just go to their doctor and get the drug and not have to do their study visits. So there's actually interpretation issues that we have to do in these data sets, though the data looks like those patients who continued had continued control of their disease. So that's one thing we want to see. And so far, our biologics in atopic dermatitis seem that they do very well with extended use beyond the short-term time periods, at least from a population standpoint. And we've had a few studies that I think inform practice. This is one where this is looking at the left part on patients who made it to clear or almost clear or EASI-75 response. So patients were sort of responders, and what happened to them? So you see that 100% in entering part 2 had that, because that's the definition. We're looking at all those patients who did well. But what I'm interested in is that gray line. That gray line is those patients ended up going on to placebo at that point. And you can see between week 16 and 52, so basically for the 8 months afterwards, only 50% of people lost their clinical response, which is actually pretty good. So it does show you, is there a disease-modifying effect? I don't know. Am I going to stop my patients and see how well they do? No, that's going to be a decision I'm going to make with my patients. But we're not seeing a tremendous amount of rebound. And then the last part of the curve is that there's what we call recapture, where patients recaptured their response. I think the recapture rates look good. For me, I'm very excited by the next set of data that was just released in a press release and then at a symposium at the EADV, which is looking at the data for use of dupilumab in patients like this. This is one of my 5-year-olds in clinical practice with miserable disease. And so this is the first data we're seeing of the younger cohorts used with dupilumab. So these were patients 6 months to 5 years of age with moderate to severe atopic dermatitis. Interestingly, the 6 to 11-year-old data previously was in severe atopic dermatitis. And this was a placebo-controlled trial without a loading dose, and patients basically had weight-based dosing of either 200 or 300 milligram, all of them at Q4-week intervals. You can imagine younger kids are really happy with less shots rather than more shots. And the outcome measures were the traditional outcome measures. So you can see a nice spread between vehicle and active. 28% of patients made it to clear or almost clear. 53% EASI-75 within the 16 weeks. Now there's other aspects of the disease population that we're not going to go through in terms of how severe a population was it. Other outcome measure, if you look at the EASI score, there was a 70% decrease in the EASI score in the patients, as compared to 20% with a placebo and 49% reduction in base in the IT score. For comparison, I've listed the EASI-75 results that we've seen in the prior pediatric studies, the adolescent study, which had a 42% EASI-75. In the 6 to 11-year-old, it was 67%, but actually 75% in the approved dosing. What I think is especially interesting is the chart on the right, which looks at infections. So we know in clinical practice that younger kids have a lot of infections. We have kids hospitalized pretty much every week with eczema herpeticum or secondarily infected eczema. That's part of children's hospital practice, and that's trying to send people out of the ED many times with empiric antibiotics and acyclovir to keep them out of the hospital unless they're really sick. Infection rates were a third in the dupilumab group as compared to in the placebo group. And the skin infections were similarly decreased as well. So markedly, actually, let's see, I got it. Yeah, it was a third in infections. The skin infections were twice as common in the placebo group. And this was with topical corticosteroids in both groups. So very, very exciting information. Now, I will comment, my own personal comment. I think that the 6-month to 2-year-old group, even the aggressive pediatric dermatologists in the country are going to be like, wait a minute, I think we need more data. We really sort of want to know how it might mediate disease over time. It doesn't mean we're not going to use it, but it's going to be a little bit different, I think, than our interpretation of the 2 to 5-year-olds, which we'll just look at as, yeah, they're younger than 6, and work our way down. So questions, what will AD treatment look like under age 6? They just got approval of dupilumab down to age 6 for asthma as an add-on therapy. I don't know if you heard that prurigo nodularis, basically the clinical studies showed that the dupilumab met the primary and secondary endpoints for prurigo nodularis. So one of the questions is how approval in other disease states or in comorbidities might mediate its use. Now, from a summary standpoint, we have tralokinumab, lebrikizumab, and nemolizumab as 3 biologic agents that I'll highlight, though quickly. So tralokinumab and lebrikizumab being IL-13 monoclonal antibodies, and nemolizumab IL-13. So tralokinumab has completed its core phase 3 studies. It's approved already in the EU, Iceland, Norway, and Liechtenstein for treatment of moderate to severe atopic dermatitis, and we're awaiting FDA approval. And I initially had like a whole set of data slides. I still put a few in, but we don't really have the time to go through them all, except to say that, recently at EADV, we started to look at some data sets where they looked at the predictiveness, what aspects in a data set could predict extended clinical response with tralokinumab. Very interesting methodology where they threw in, thousands of data points. And unfortunately, the takeaway is that those patients who responded by 16 weeks were the ones who responded long-term as well, which sort of makes sense. But we love this kind of an analysis in the future, because what we want to really be able to do in our systemic therapies is potentially figure out what either biomarkers, phenotypic or genotypic markers, might predict differential response for different agents, but we're not there. And I think I'll probably skip through the other data on long-term maintenance. And skip on to 2 papers that just came out related to tralokinumab. One paper, the Extra 7, which is tralokinumab plus topical corticosteroids with severe AD and inadequate response to cyclosporin, which just came out October 26th, and October 12th, the conjunctivitis roll-up of showing conjunctivitis rates of around 7.5% with tralokinumab, as compared to 3.2% with placebo. Lebrikizumab, we don't have new data on this IL-13 blocker. We've seen the phase 2 data previously. There was a press release, though, that said that it met the initial phase 3 clinical trial results, and there are several posters being presented at this meeting, not core phase 3 clinical trial data, but other data looking at the drug. Nemolizumab, we know it's targeting the itch cytokine, and paper pretty fresh, came out November 2nd. So yes, yesterday just came out, and I think Kenji, who's one of the Kenji Kapashima is the first author, is a part of this meeting this weekend, and this is looking at the core outcome measures of patients who were initially on 60-week of therapy and then rolled over to a 52-week extension, and so they were either randomized to Nemo, stayed on Nemo, randomized to placebo, and flipped over. And basically the summary result is that the clinically meaningful improvements at week 68 in the pruritus visual analog scale, 78% decrease in EASI scores, and some quality of life indicators changed as well. It's about as much we can take away from a paper that came out just yesterday and I just glanced at. There are other biologics that are on the way as well. The OX40 pathway, you can see that I've listed 3 medications that are well along the way. Recent data has been presented at EADV and at the SID, and I don't have time to go through them. Interesting impact on pathogenesis of these drugs. They may have prolonged effect even months after they're given to individuals, and we will see how they will play out over time. So from a big standpoint, sort of a perspective on biologics, I think Having choices of different medications is good from a patient perspective. The oral JAK inhibitors are going to be discussed later today, and we're all going to be doing a compare and contrast, figuring out what the sequences of biologic agents as compared to oral agents. I think we'll be working on selecting patients for therapy, which should really be patients selecting therapy with guidance by their clinicians. But there are clearly some factors that are going to influence our decisions about biologics or non-biologics. And just listing a few: age of patients, the sex of patients, because some medicines have concerns with pregnancy, others may not as much so. Comorbidities, some are going to treat more than one comorbidity. What prior therapy the patients had. Risk aversion, because we're going to be in a situation in dermatology where we have to pick our patients. Patient selectivity and risk management is something that we'll have to do with some of our drugs. Desired efficacy, I don't know if Brett in this afternoon is going to be including some of the head-to-head trials of oral JAKs as compared to the biologic agents, because there can be profound efficacy with some of the oral agents. And then the planned duration of therapy, and then access, because having a drug to actually get into the hands of our patients is something that takes a lot of work in our clinical practices. And with that, I'd like to thank the IEC and NEA and Natasha, Emma, and Julie for putting together such a great meeting and for including me. Thank you.